All right, thank you for joining us for today's event on Inpatient Rehab Facility Under Review. My name is Mary Sue Gardner, and I'm a registered nurse from the Provider Outreach and Education Department. And I'm going to be your facilitator for today's event. I'm also joined today by other members of Provider Outreach and Education, as well as Medical Review, who are going to be helping with the chat and any questions and answers for today's call. A few housekeeping things before we get started. On our website, WPSGHA.com, we have a training center link at the top of the page. In our training center, you're going to find all things education, such as the training materials like the slide deck for today's event, any upcoming educational events, and even access to our encore presentations, which are the recordings of our live event that we hold on our host on our YouTube page. Those encore presentations are generally on our YouTube page until new information is given on the service or they're outdated and need to be changed. But we have a link to the encores on our training center, and those are up for about 60 to 90 days. So that's a way you can watch the recording of the event without actually going to YouTube, because we have a built-in YouTube player in our website. If you have any questions during today's event, place those questions in the chat and send those to everyone, and our panelists can help get those questions answered. Finally, if you have any feedback about your experience today, there's going to be opportunities now and at the end of this event to take our survey. So Jennifer's going to place a link to the survey in the chat right now and at the end of the presentation. So if you find you have to leave the presentation early, we're scheduled to go till 2 o'clock, but if you have to go early, we do encourage you to go ahead and use that link and go out and get the feedback on today's event. Also, it gives you the opportunity to let us know what else you need in the future. On your screen is our disclaimer. We have to give our disclaimer at the beginning of every one of our events. And what our disclaimer basically says is, we prepared this information as a tool to assist you, our providers, in the Medicare laws, rules, and regulations. But as a Medicare provider, you must know that those laws, rules, and regulations often change. So the basis of the answers we're going to give today will be on the laws, rules, and regulations as they stand today. But if CMS decides to change those laws, rules, and regulations tomorrow, it's your responsibility as a provider to make sure you are following the regulations that are in effect on the day you are providing services to a Medicare beneficiary. We also ask that you do not audio or video record this presentation. We're actually doing that for you, and we will be posting it as an encore for our live events on our YouTube page. Acronyms. There's a bunch of acronyms that are listed that I may or may not refer to in the course of this presentation today. Since Medicare is full of acronyms, I just wanted to put the most common ones that are used in this presentation on a slide for you. So if I happen to use an acronym that you're not familiar with, just refer back to this slide. And if I give an acronym that is not on this slide and you don't know what it is, just go ahead and put it in the chat and one of my associates will provide that answer for you. So why are we here? My objective for today is to help our IRF facilities avoid costly errors and to improve your documentation compliance. And we're going to accomplish this today by going through the agenda items. So we're going to go through the IRF coverage criteria so you have a better understanding. We're going to learn about key documentation requirements. We're going to review some of the actual medical review findings that our review nurses see. And we're going to discover in all of this how to avoid some of those common compliance mistakes. So as for our agenda, let's start the webinar by discussing the Medicare coverage criteria for IRFs. The Benefit Policy Manual, so that's the Internet-only Manual 100-02. Chapter 1 of that manual, Section 110, actually defines the IRF benefit as a benefit which is designed to provide intensive rehabilitation therapy in a resource-intensive inpatient hospital environment. And it's for patients who, because of the complexity of their nursing, medical management, and rehabilitation needs, they require and can reasonably be expected to benefit from an inpatient stay in an interdisciplinary team approach to the delivery of rehab care. So there's key words in there that are listed here on your slide: resource intensive, inpatient hospital, complex nursing, medical management, and rehab needs, and your patient's got to benefit from the stay and benefit from having an interdisciplinary team approach. So again, your slide summarizes all these points. So thinking of your patient that needs to come to your IRF, think about these things that are listed here on the slide. Do they need that resource-intensive hospital stay? Do they have complex nursing, medical management, and rehab needs? Are they going to benefit from your type of service in an interdisciplinary fashion? Intensive rehab services. Remember that I'm probably going to say a million times interdisciplinary team. So interdisciplinary means that all the resources are working together. Multiple disciplines and interdiscipline are not the same. Just because the facility offers multiple disciplines of service doesn't mean that they are working together and having meetings and working towards common goals of getting the patient better and hopefully discharged from the facility. So skilled nursing facilities have multidisciplinary teams, but they don't necessarily work as an interdisciplinary team. So let's move on into medical necessity and talk more about what the patient, what types of things meet our medical necessity requirements in the IRF environment. So when you are considering if a patient needs your type of setting, let's think about how the patient is at the time of admission. Back in the day, there used to be a ramp-up period that the patient could come to an IRF and ramp up to be ready in the first several days. That no longer exists. Medicare now says that at the time of admission, that patient must require multiple disciplines of service that are working together and acting as an interdisciplinary team. They must need an intensive rehab program that requires those multiple disciplines. And again, one of those has to be PT or OT. They have to be able to actively participate in that intensive therapy and show measurable improvements from the get-go. So actively participate. Remember, the IRF setting is geared towards active improvements. So you must show the patient is benefiting from the service. So we're going to talk about what constitutes intensive therapy and active participation in a little bit. Now, the services in the IRF must be supervised by a rehabilitation physician who is determined by the IRF to have specialized training and experience in inpatient rehabilitation. And that's according to the Code of Federal Regulations, which is CFR 412.622. I'm going to actually just put that Code of Federal Regulations link into the chat for you. Again, all of this must be delivered in an interdisciplinary approach. So remember, the IRF benefit cannot be used as an alternative to completion of a full course of treatment from the referring hospital, like from the acute care hospital. The patients had to complete the full course of treatment in that referring hospital and ready for discharge from them. They should, if they haven't completed that, they should just remain there, because they must be able to actively participate at the time of admission. So if there's something that's hindering them from active participation, again, they shouldn't be discharged from the acute care or admitted, to your facility. All right. So let's move on with talking about the pre-admission screening. So pre-admission screening is part of your conditions of coverage. It's a screening or an evaluation of the patient's condition and the need for rehabilitative therapy and medical treatment. So it must be conducted by a licensed or certified clinician. It needs to be completed within 48 hours immediately preceding the IRF admission. The pre-admission screening that includes all of the required elements, but that's conducted more than 48 hours immediately preceding the IRF admission. We will accept that as long as an update is conducted in person or by telephone to document the patient's medical and functional status as it is within that 48 hours immediately preceding that IRF admission. So the pre-admission screening in the patient's IRF medical record, it actually serves as a primary documentation by the IRF clinical staff on the patient's status prior to admission and the specific reasons that led that IRF clinician to conclude that IRF admission would be reasonable and necessary. So as such, the IRFs must make this document detailed and comprehensive. I cannot stress that enough. The pre-admission documentation, or PAS, must indicate things like the patient's prior level of function, and that's prior to the event or condition that led to the patient's need for intensive rehab. So, not forever ago, what happened immediately preceding the illness, injury, accident that caused the patient to have that acute care stay and now need the IRF stay. All right, we must also have the expected level of improvement and the expected length of time that's going to be necessary to achieve that level of improvement. The pre-admission screening must also include an evaluation of the patient's risk of clinical complication. It needs to include the conditions that cause the need for rehab and whatever treatments are going to be needed, such as PT, OT, SLP, prosthetics, orthotics, etc. And it has to contain anticipated discharge destination. So if the patient is being transferred from a referring hospital, the pre-admission screening could either be done in person or through a review of the patient's medical record from the referring hospital, either paper or electronic format. So as long as the medical records contain all the necessary assessments to make, a reasonable determination for this patient. However, pre-admission screenings that are conducted entirely by telephone should generally include a transmission of the patient's medical records from the referring hospital to the IRF and a review of those records by that licensed or clinical staff member in the IRF to ensure it includes a detailed and comprehensive review. So make sure you are getting everything. As an IRF, you should develop a thorough pre-admission screening process for your patients that are coming into the IRF, especially if they are community-based patients. Make sure you have a good screening process for them as well. And there's information in that Code of Federal Regulations that I attached on that as well. All right, so again, the focus of the review of the pre-admission screening information will be on its completeness and its accuracy and the extent to which it supports the appropriateness of the IRF for your beneficiary and the appropriateness of their admission, not on how it was processed or organized. So again, make sure when you are sending someone out to do your pre-admission screening that someone is a licensed or certified clinician. That person is approved by your facility to do the pre-admission screenings. That person knows how to assess a patient for medical as well as functional needs and could write a plan based on those expected medical or functional needs, as well as include information on expected frequency and duration of those different types of service and anticipated discharge destination. As I've mentioned before, IRFs must offer and have available multiple therapy disciplines. And so these disciplines are included here: PT, OT, SLP, prosthetics, and orthotics. One of them must be PT or OT. So the primary distinction between the IRF and other rehab settings is the interdisciplinary approach, which we'll move into and talk about in a little bit. Patients that require only one discipline of therapy would not need an interdisciplinary approach to care. So for this reason, the information in the patient's IRF medical record must document a reasonable expectation at the time of admission to the IRF that the patient required active and ongoing and therapeutic interventions of multiple disciplines, and that those multiple disciplines need to work together. So as I said, I'm going to talk a little bit more about the intensive rehab program. All right, the primary distinction between the IRF environment and other rehabilitation settings, again, is that interdisciplinary or other settings is the intensity of rehab that's provided in the IRF. So for this reason, the information in the IRF's medical record must document a reasonable expectation at the time of admission to the IRF that the patients require that intense rehab and therapy services, and that those are services, that are unique to the IRF. Although the intensity of rehab services can be reflected in a variety of ways, the generally accepted standard by which the intensity of these services is typically demonstrated in the IRF is by the provision of intensive therapies at least 3 hours per day, at least 5 days a week. However, being IRFs, you know that this is not the only way such intensity of services can be demonstrated. Excuse me. In certain cases, the intensity can also be demonstrated by the provision of 15 hours of therapy a week over 7 consecutive calendar day periods, starting from the day of admission. Remember, day 1 is the date of admission. So in cases where a patient maybe has chemotherapy or, other treatments that would take them out or be, disqualify them from 3 hours a day, 5 days a week, but they could do 15 hours a day over 7 days, then we would accept that intensity as so long as you document it and let us know why you're taking a different approach. So continuing with the intensive level of rehab services, as I stated on the last slide, the provision's generally 3 hours, 5 days a week, or in certain cases, 15 hours over 7 days. Additionally, intensive rehab services must start within 36 hours of midnight of the day of admission. So therapy evaluations are generally considered to constitute the beginning of that required therapy services. So as such, they should generally be included in the total daily, weekly provision of therapies that's used to demonstrate the intensity of therapy services provided in the IRF. The standard of care for IRF patients is individualized, so one-on-one therapy. Group therapy serves as an adjunct to individual therapies in those instances which group therapy better meets the patient's needs on a limited basis. So the situation or the rationale that justifies group should be specified in the patient's medical record in the IRF. But again, we are going to look to see the majority of the services provided for your patient are individualized therapy. Now, there can be a brief exception to the intensity portion of the policy. So here's the rules and here's the exception to the rules. While a patient is receiving IRF care, if the need happens to arise and a patient has an unexpected, let's say, clinical event during the course of their stay that limits their ability to participate in an intensive therapy program for a brief period of time. That brief period of time is, it cannot exceed more than 3 days. The person gets a flu, the person, has to leave for a funeral. I don't know, something hinders them from receiving that for a brief period of time, not to exceed 3 days. We can allow for that. The only exception is it has to be well documented and it can't be within the first 3 days of admission. Because remember, as I said, they need to hit the ground running and there is no ramp up. So there is no brief exception in the first 3 days of admission. All right. The information in the patient's medical record, especially the documentation portion, which we'll talk about in a little bit, must document a reasonable expectation at the time of admission to the IRF. The patient's condition is such that the patient can reasonably be expected to actively participate in and benefit from that intense rehab therapy program. So again, just as I keep saying, there's no ramp up anymore. You have to be able to hit the ground running. You have to be, your beneficiaries need to be able to actively participate from day one, and we have to see that they are going to benefit from and make measurable improvements. All right, another part of the conditions of coverage is the physician supervision. So there is a high level of physician supervision that accompanies the provision of intensive rehab services. So for this reason, the information in the patient's medical record must document a reasonable expectation, again, at the time of admission to the IRF, that the patient's medical management and rehabilitative needs require an inpatient stay and close physician involvement. Close physician involvement in the patient's care for IRF is demonstrated by documented face-to-face visits from that rehab physician at least 3 days a week throughout the patient's IRF stay. And that begins from day of admission. Now, beginning with the second week of admission in the IRF, a non-physician practitioner who's determined by the IRF to have all the specialized training and experience for inpatient rehab, that person, that non-physician practitioner, can conduct one of the 3 required face-to-face visits with the patient per week. But again, remember, that's starting in the second week of services, and they can do one of the 3. All right. Again, in the second, third, and fourth weeks and beyond, CMS will allow for that non-physician practitioner, again, to do at least one of those specialized treatments. All right. Now, I know I harped on this a lot today, but I want to make sure we break this down for the coverage criteria as best as possible so you know what review entities are looking for. Again, I harped on the fact that an interdisciplinary approach is required, but let's talk about some of the required components for this approach. An IRF stay will only be considered reasonable and necessary if, at the time of admission to the IRF, the documentation in their medical records indicates a reasonable expectation that the complexity of the patient's nursing, medical management, their rehab needs, all of those require an inpatient stay, and all of those require those disciplines working together in a team approach to deliver that rehabilitative care. So the complexity of the patient's condition must be such that your rehab goals indicate in the pre-admission screening and the overall plan of care that they can only be achieved through this type of service. That there's going to be periodic team conferences that'll be at least once a week, and all the interdisciplinary team staff and medical professionals will be present for that. So interdisciplinary services are those provided by a treatment team in which all of its members participate in a coordinated effort to benefit the patient and the patient's, significant others and caregivers many times. Interdisciplinary services, by definition, cannot be provided by just one discipline. So though individual members of the interdisciplinary team can work within their own scope of practice, each professional is also expected to coordinate his or her efforts with the overall team members of all other specialties, as well as the patient and their significant others and caregivers. So again, the purpose of the interdisciplinary team is really to foster frequent, structured, and documented communication amongst all disciplines. And they do that to establish and prioritize and achieve the treatment goals. So the team members, who has to be present? And again, in that CFR that I provided you the link, the team members that must be present and documented are a rehab physician who is determined by the IRF to have specialized training and experience in inpatient rehab. You must have a registered nurse with specialized training or experience in rehab. You have to have a social worker or case manager or both. And there needs to be a licensed or certified therapist from each therapy discipline involved in treating the patient. The interdisciplinary team has to be led by the rehab physician, either in person or remotely, which could be via mode of communication such as video or telephone conferencing. And that rehab physician is responsible for making the final decisions regarding the patient's treatment in the IRF. Okay, so I do see a question that came in, and it says, can you please expand on what is required to be documented to qualify as a valid face-to-face visit? So just as with any other like E&M visit, the physician would need to document, and I'm assuming you mean for the physician required face-to-face or the non-physician practitioner, require what was discussed with the patient. We usually see those in progress notes, what time frame, if time is of essence, what the physician reviewed with the patient, family, caregivers, etc. if there was any labs or whatever that would discuss. Again, usually when we're going to look for this information, we look for it in the progress note, and the physician or non-physician practitioner has made some sort of note about what the visit entailed. If they did assessments, what they saw, if the patient has medical things they are managing, if there was any changes to medications, etc., all of that could be documented. And then, can the remotely led meeting be remote for all of the team, or can the physician just be remote? The CFR does not say the rest of the team has to be in person, but an old webinar from CMS said the rest of the team has to be in person, but I personally don't know why. So Jennifer, I am going to ask medical review to chime in on that in the chat notes, if they would, because I am not certain. Yes, the CFR does not specifically say that other team members cannot be on remotely too. It just says that all team members must be present and participate, and the physician needs to document everyone that is there, their professional designation, and their participation. So just watch the chat, and I will have someone from medical review chime in on that as well. All right, moving on. Let's talk about that team conference. As I said at the last slide, the team conference must be led by the physician. So this physician must document concurrence with all decisions made by the interdisciplinary team in each meeting. So the periodic team conferences have to be held at a minimum of once per week. And that conference must focus on assessing that individual's progress towards the rehabilitation goals. It must focus on considering possible resolutions to any problems that could impede progress towards those goals. We have to see that it also focuses on reassessing the validity of the rehabilitation goals that were previously established and monitoring and revising the treatment plan as needed. So again, if you think of the team conference and the focus, really we're looking at those overall goals that were established by the physician and the team for this patient. And every time you get together, there should be a discussion of how are we progressing towards these goals. If we're not going to meet them, why are we not going to meet them? Do we need to change something? Is there things that some of the disciplines can do to help better achieve those goals? And revise those goals if they are no longer relevant for the patient. All right. Staying on this team conference, does a physician's signature stating all required team members were present meet the requirements, or does each team member need to sign? And the answer to that is no, each team member does not need to sign, and it is written in the internet-only manual, the benefit policy manual as such, but the physician does need to say who was there and what their professional designation is. So we know that everyone was present for those team meetings. And then if the patient is being discharged on the day of the team conference, is the team conference still required? If your patient is being discharged, no, your team conference would not be still required, even if it's, to that date. But if you didn't know they were discharging and you still had the conference, that's fine. You just include that information in your overall notes. All right. Moving on, a little bit more about the team conference. Again, it's your decision as an inpatient rehab facility to decide the format of your team conference. It can be formal or informal. However, it cannot just be a review by various team members from each other's notes. So you can't just pass something around and everyone sign off. It has to be an actual conference of such where you are all speaking together and all working towards common goals. So it's, again, expected that all treating professionals from required disciplines will be at the meeting. In the infrequent case of an absence, absent, gosh, I can't speak today, you should send a different representative. So if it's nursing and you're the nurse and you can't be there that day, you should send another registered nurse to stand in for you that day. So the point of it is that everyone from every discipline actually attends and interacts within the meeting. And not that just someone stayed in their area doing their thing and just read the meeting notes and signs off on it. That does not meet the definition. All right, so documentation at each team conference should generally include, again, names and professional designations of each participant in the conference. And again, the signatures are not required other than the physician's signature that, you know, everyone was there. The physician who is the facilitator just needs to document who was there and their professional designation. All right. If a patient is admitted on team conference day after team conferences are held, the next team conference day would be 8 days out. Is this acceptable for patients that are admitted after team conferences are held on team conference day? So no, the answer to that is no. You still need to meet the time frames of weekly. Just because your facility sets every Tuesday as your team conference day, if you have a patient that's admitted on a Tuesday and so they're not even going to get a team conference until the next Tuesday, if they're outside of that 7-day window, you would not be meeting the requirement for that. Our therapy session be conducted by qualified assistants like PTA or OTA, or does it have to be a PT or OT? No, as long as it's okay for therapy assistants in your state to participate, therapy assistants can provide some of your daily services. And does the therapist who treat the patient have to be present, or can the therapist from the discipline report at the meeting if they are a handoff from the primary? Does the therapist who treated the patient have to be present, or can another therapist from that discipline report at the meeting if they're a handoff? Okay, from the primary therapist. Yeah, so the way the regulations are written on that, Jennifer, is that a therapist from that discipline needs to be present at the team conference. Now, it is best to have the therapist that is actually treating that patient attend the team conference. However, in the event that that therapist cannot attend, yes, it's okay for another therapist to treat that patient. All right, moving along with measurable improvement. So a patient can only be expected to benefit significantly from an intensive rehab therapy program provided in IRF if the patient's record indicates that they're going to have a reasonable expectation of measurable and practical improvement in the patient's functional condition. And that can be, you know, determined in a predetermined or reasonable period of time. So in general, the goal of the IRF treatment is to enable the patient's safe return to home or community-based environment upon discharge from the IRF. The patient's IRF medical record is expected to indicate both the nature and degree of expected improvement and expected length of time to achieve improvement. And usually, and you think about this, when the patient is already in your facility, these are things that are being addressed by your PT, by your OT, by your SLP, by prosthetics, orthotics. That's part of their individual care and how long it's going to take them. But as a team, you're going to want to consider how long will it take you in a predetermined amount of time, a reasonable amount of time to achieve your overall goals. So what do you think as a team that this patient is going to need to enable a safe return home or to their community environment? So an IRF stay, can be considered reasonable and necessary, and the patient doesn't have to be expected to achieve complete independence in the IRF stay or complete self-care or even a return to his complete, prior level of function. Sometimes that is just not going to happen. However, to justify the need for the continued IRF stay, the documentation in the IRF medical record really needs to demonstrate the patient's ongoing requirement for intensive level of rehab services and that interdisciplinary need or interdisciplinary team approach. So again, we need to see that the patient's making functional improvements that are going to be sustainable, as well as they're going to be of practical value and measurable against their condition at the start of treatment. Since in most instances, the goal of the IRF stay is to enable the patient's safe return to the home or community environment upon discharge, the patient's treatment goals and achievements during the IRF admission are then expected to reflect, that significant and timely progress towards this end result. So again, emphasis of therapies would generally shift from traditional patient-centered therapeutic services to patient caregiver education, durable medical equipment and training, and other similar therapies that are going to prepare for this patient for a safe discharge out of this facility and a return to home or community-based environment. Which leads me to documentation. Before we go to documentation, can you have a discharge goal to get to a SAR in any case? If the IRF stay will allow for less burden of care in the SAR, is that benefit that is allowed? Anything you can do to help define generally would be great. The discharge goal to get to, what is an SAR, Jennifer? Like a nursing facility? I'm not sure what that acronym is. SAR equals SNF. Okay, so let's talk about that for just a second before we proceed on with documentation. If your overall goal from the time of admission is for the patient to come into you and then go to a skilled nursing facility, does the patient need you? The things that you need to prove, with a reasonable amount of doubt is, why does the person need the inpatient rehab facility and the interdisciplinary type of treatment? So if those things are necessary, if they need the treatment plan, if they need everyone working together, if they need your high intensity level of service and everyone working together and not just multiple disciplines, then it may be appropriate for the person to come to you and still go to a skilled nursing facility in the end. But if they're just going to end up going to a skilled nursing facility because they need PT, OT, and maybe SLP, but they don't necessarily need all these services to work together, they don't need the clinical staff, they don't have those multi-medical needs as well as rehabilitative needs, then they probably shouldn't come to you in the first place. There will be times that, the patient was expected to go home, was expected to go to a community environment, like maybe assisted living. They get to you, you guys do all the good things that you do. However, in the end, the patient just was not able to sustain it, or maybe they were not able to actively participate at the high level that was needed. So ultimately, they end up going to a skilled nursing facility despite all your best efforts. And that's okay. That happens, and we know that happened. But if, like I said, the beginning goal was really to say, oh, we're going to bring them in here, and then they're going to go to a SNF and receive basically the same services, then they're probably not the best candidate to come into the inpatient rehab facility to start with. All right, moving on with documentation. So I'm going to go through these documentation guidelines kind of quick because we have talked about almost all of these already. So the pieces or the components of documentation that are required, that pre-admission screening, and it has to be completed or updated within 48 hours of admission. And it has to be completed by a clinician, and it has to be reviewed by the physician prior to admission. Your IRF PAI, which you all know has to be completed. A copy of the IRF PAI, if we request records from you, which would be on a post-payment basis, we need a copy of that PAI to be submitted to us as well, whether that's the electronic version or a hard copy version, etc. Individualized plan of care. We talked about this a lot too, and that individualized plan of care has to be completed by your rehab physician within 4 days of admission. Again, synthesized is the word that the internet-only manuals use, synthesized by the rehab physician. And then we need therapy. Basically, anything therapy touches, we want to see. Evaluations, progress notes, daily treatment notes, etc. If it is in the therapy documentation, you should submit it if we request documentation for review. And then finally, the team conference notes or the interdisciplinary team conference notes. Again, we need to see that it was led by the physician. We need to see all the disciplines were involved and that they were actively participating in the progress towards the goals of the team. It does not need to include all the other members' signatures. It does need to include the physician's signature since they're the one leading the team, and that physician does need to make note of who was there and what their professional designation is, so we can see that all people were actively involved. When it comes to physician orders, physician progress notes, again, anything your physicians document on, certifications, etc., we want to see all of those. Nursing, your progress notes, your assessments, your flow sheet, medical, your MARs, IV MARs, we want to see all of that. If there's any kind of respiratory stuff that you do, we want that to be included as well. Social worker and case management notes. So we need all of your notes as well. And then information that came from the acute care records. If you have that information, if it was sent to you, we would expect that you would submit that to us. And if an ABN were happen to be issued, we'd want to see a copy of that ABN in your file as well. So I want to really quickly cover the pre-admission screening requirements again because they're so important to make sure they are documented. So not only are they a coverage criteria, but a documentation component that we have to have. So this is the initial factor in determining if someone if they're eligible, if they should be coming to your IRF and your IRF level of care. So I want to make sure that your documentation for the pre-admission screening is spot on. So things that we will look for in the pre-admission screening. Was it done within 48 hours of admission? If not, was it updated within 48 hours of admission? Remember, You can update in person or by telephone, but your update must include where the patient is from a medical aspect as well as functional aspect on that day that you update it. And again, it's got to be conducted by that licensed clinician. So again, 48 hours immediately preceding, more than 48 hours, update it. The update can be in person or by telephone. Again, include those statuses. All right, so indications in there. Patient's prior level of function, expected level of improvement, expected length of time necessary for improvement. Evaluation of the risk for clinical complications, any conditions that cause the need for rehab, what treatments are going to be needed, and anticipated discharge disposition. And that all of this information is shared with your rehab physician prior to admission. And this right here, this is why it needs to be a clinician. It can't just be a rehash of the inpatient chart. So if someone goes out and just copies the inpatient chart, they're not doing this evaluation of the risk for clinical complication. They are not evaluating what conditions cause the need for rehab, what types of treatments are going to be needed. They're just jotting down the information that was already in the chart. Any Joe Schmo can go do that. That's what makes IRF so different, is that we have the people necessary to make the determinations, to go out and accurately assess the patient to make sure we're bringing in the correct people. All right, and then again, I want to circle back around to this because it's of utmost importance to make sure you're documented here well, as you know, you document well here too, in your individualized overall plan of care. Remember, when we look at the plan of care, we're going to be looking that it was completed by the physician, that it was completed timely. The first one within the first 4 days. We're also going to look to make sure the information from the pre-admission screening and therapy clinical discipline was taken into consideration in formulating the plan of care. The physician must also document detailed medical prognosis, anticipated interventions for all the services. So it's here that we're really going to be looking to support medical necessity. And then finally, I'm just going to spend the next couple of minutes and talk about some of our overall medical review findings and how you can avoid those. And then I'll go back and circle back to the questions in the chat. So the first issue, documentation lacks the necessary components from the team conference. And we went over this a lot. So things that we often see, not all key participants are present. And that's generally because like names or professional designations or credentials were not listed. So it may list Sally, John, Erica, and Steve, but we don't know what departments they represent. So therefore, we can't say you met the necessary components. Or maybe it just says PTOT, SLP were present, but we don't know who. So we don't know that it was an actual physical therapist or occupational therapist, you know, et cetera, that was present. We need to see information on frequency. We need to make sure that they meet at weekly intervals and not more than the weekly intervals. So you can meet as often as you want. You can meet every day if you wanted, but you can't meet less. You have to meet at least once a week. We also find that sometimes the team conference lacks goal assessment and progress. All right, other issues under team conference are no listed resolution to problems that could impede progress. So if there's something that comes up that could hinder your patient's progress, you need to be thinking of resolutions, and you need to document those resolutions. If there is no documentation of physician agreement with the team, that's an issue as well. And then finally, the documentation doesn't support it was synthesized or led by the rehab physician. As we move on, conflicting information and notes. So conflicting date of service or team conference notes are not signed by the physician, but then there is a notation by the physician, but it was on a different date. Conflicting information on the patient status between modalities of service. So let's talk about this a little bit more. So team conference notes, again, not signed by the physician. So we don't know if it's not signed and dated by the physician, we really don't know if it happened on that day. We have seen notes that it was dated, but there was no physician signature. And then a physician comes back and signs it, but the date is 3 days later. So again, we don't know exactly when it happened. And then again, conflicting information on patient status between modalities of service. One modality says, you know, the patient's walking with two-person assist, and nursing's documenting they can't even get a patient out of a wheelchair safely. So, you know, when there's conflicting information like that, we have to wonder which service is, you know, correct. If there's times when patients act different based on their diagnoses. Maybe the patient has sundowners. Maybe the patient does really well during the day with therapy services, and then for whatever reason at night does not do well with nursing services. If there are noted things like that, that should be something you're taking back to the team conference and discussing, so it doesn't just look conflicting in your overall documentation. All right, next is your pre-admission screening findings. So lacking the necessary components. Really, no prior level. They just don't justify the need for admission, so they're just a regurgitation of the inpatient notes. There's no indication of what types of services are going to be anticipated. Maybe again, because they were just a regurgitation of the patient's note. There was no assessment of risk for clinical complications. And then again, frequency and duration, discharge disposition, no documented review and concurrence with the rehab physician prior to admission. So remember, that has to happen as well. And then finally, the last issue, and this is not just an inpatient rehab facility issue, but happens in a lot of services, is no documentation was received. So the ADR request went out for the documentation to submit it, and the facility did not respond within that 45 days. That constitutes a 56900 or 56900 error. It is a claim denial. There is no appeal on a 56900 denial because there was no medical necessity decision made. It is a technical denial. If you happen to receive that, you must submit for a clerical error reopening if you want that claim to be considered for payment. So that's the only way to get payment for that. So before I go to the questions, let's recap. We went through a lot. We reviewed how to avoid these costly errors, and we did that today by really diving into the coverage criteria and documentation and what types of things you have to have in your documentation and what we're currently denying claims for, because most of it is lack of documentation, and so how to avoid those. So I'm going to look over to the questions. And let's see, any guidance on who the clinician can be that completes the prior admission screening? What clinicians count or do not count? Any licensed or certified count? You know, in most cases, it is your rehabilitation nurses and therapists that are those that are most qualified and trained to assess a patient and write, you know, what that patient is going to need as far as therapy services, nursing services, medication management, etc. So I'll let Linda chime in on that as well in the notes if there is any, you know, anyone that they don't consider. But really, to be safe, think about what the requirements are and what you need to gather, and the decisions that need to be made on formulating what kind of service, what kind of medical management, how long it's going to take, etc., when you're considering who needs to go out and do that. Let's see, can you expand on what it means, risk for clinical complications? So you need to take into account, Stella, what medical management is being done for that patient for whatever diagnoses that patient has. And if there are any risks for any additional clinical complications, if you don't monitor, actively treat, assess for those things on an ongoing basis. If that patient is, you know, has been having some brittle diabetes because of maybe some orthopedic surgeries that they have had, and now they're on a very tight sliding scale that they are up and down on, and it has to constantly be monitored 5 times a day, you're assessing those risks for clinical complications. You are doing the things that you need to prevent those services. So again, taking into mind all medical diagnoses that your patient has, what are we doing to prevent them from having some sort of complication from that diagnosis that is going to inhibit them being able to actively participate at least 3 hours a day, 5 days a week in rehab services. And then finally, TC notes must be signed by the physician on the date the conference was conducted. So not okay to sign the next day if pulled away for an emergency. If your physician was pulled away for an emergency and just did not get a signature on there, that physician should be making a note of the day that happened, and that physician was unable to sign on that day based on that emergency. So there should be some addendum to your note. If there's no addendum, it's going to look like that the patient or that the conference didn't happen on the day it happened. So make sure there is some sort of justification in the documentation of what happened and why that physician did not sign on the date of service. And I know we are just a little over call start time, so I am going to move forward in the interest of time because I appreciate you sticking with me for these last couple of minutes. In a few minutes, you're going to receive an email, if you haven't already. It's your certificate of achievement. It basically says, thanks for attending this event. It looks pretty much like this. But if you need continuing education credits, you have one contact hour that could be used towards CEUs in that email. So just don't delete that email without reading it. It also contains a link to our feedback survey. So you'll have a couple opportunities to take the survey. So as we move on, we'll talk about that in just a second. If you have follow-up questions from today's event, Send those questions by noon within the next 7 days following this training. So send them to this email address and the one that Jennifer noted earlier, wps.gha.education@wpsic.com. If you click on this, if you have our file deck for today and you just click on that, it's automatically going to populate an email. And then in the subject line, use today's topic. So put IRF webinar or something related to IRF. If you have claim-specific questions, those unfortunately need to go to customer service. We don't have access to the system to look those up, and we would hate for you to try to send any PHI or PII over the internet. That's going to potentially get you and or I in trouble. So claim-specific, please take those to customer service. All right, as I stated at the start and just a second ago, we value your opinion. We want to hear from you on how we did on this event. The survey just takes a few minutes to complete, and that's why we are giving you the opportunity to take it now. It's also your opportunity to tell us what additional education you would like in the future. Many of our educational events that we do are a direct result of these requests. So the only other thing is make sure you read those responses carefully, as the ranking order does change during the course of the survey. And we do ask that you, if you start it, please complete it all the way to the end. All right, and then finally, we're committed to making those changes based on that feedback. So some of the things that we have most recently changed, we've added some chapters to our YouTube, so you can open a YouTube or an encore presentation, and in the description, just jump ahead to what section you need. If you just want to hear the documentation information again, you can just switch to or link to the documentation. We also started adding some training indicators in our description, so you know what training, who the training pertains to. So things like CLIN for clinical, or DOC for documentation, or BILL for billing. So on our website, there's also a list of training indicators. And also coming up on July 15th, we're actually hosting a large-scale event all day on local coverage determination. So a local coverage determination expo. So you can sign up for any or all of that day's events that you would like to attend. And finally, on behalf of myself, as well as Jennifer and all of Medical Review, I want to thank you for sticking with me today and for your participation in today's event. This concludes our webinar, and you may now disconnect.